Thank you for joining us again for another show. Again, we have Darren Prescott, the CEO of Mobile Urodynamics Group, with us today. Welcome, Darren.
Hi, Robert. How are you?
Doing fine. Thanks for joining us. This show, I believe we're going to talk about urinary incontinence types, and starting with stress urinary incontinence. Is that correct?
That's right. We really want to determine the types of incontinence as we're starting with stress urinary incontinence today, and then at some point we'll move into more of an overactive bladder. But you're really going to determine the type based upon a history-taking, physical exam, and urodynamic study. So stress urinary incontinence is essentially where the patient complains of leakage due to coughing, laughing, or physical exertion. And
okay.
So a urodynamic study shows leakage with stress. It's a real common occurrence, particularly in female patients who've had difficult pregnancies or who are up in age, particularly if you've got a prolapsed bladder where the bladder outlet has fallen below the pelvic line. And so in a lot of cases in that situation, you lose that inherent pressure that helps keep that sphincter closed, and in turn that's where you get your continence with mild amounts of stress.
Okay. Now, my understanding is there's varying degrees of stress urinary incontinence. For our physicians that are getting into urodynamics, considering getting into urodynamics, maybe we could outline the different degrees of SUI for them.
You bet. They're really broken out into three types. The first is considered mild stress urinary incontinence, and that's when the patient leaks at a vesical pressure greater than 90 centimeters H2O. And you've got type 2, which is considered moderate, and that's where the vesical pressures are between 60 and 90 centimeters H2O. And then severe, type 3, which is pressures below 60 centimeters H2O. So it's taken very little. Below 60 centimeters H2O is really very little stress placed on the patient in order to cause a leak.
Okay. And during urodynamic study or concluding urodynamic study, how is the type of SUI, if that in fact is the case with a particular patient, how is that information provided to the doctor to determine the type?
Well, in our case, the doctor is going to receive a printout that actually shows exactly what the minimum level of stress urinary incontinence. And so what we essentially do is we're going to do our very best to try and recreate the patient's symptoms. And so we're going to typically stand the patient up, have them bear down, cough, and really try and find at the very lowest level that they leak. So if they do leak, we try and take it down a little bit more until we get to the lowest level possible. We're also going to report really clearly where that number is, and should be very little ambiguity about what level the patient is at.
Gotcha. So it would be easily determined by the physician based on the report what type and what level, mild, moderate, or severe, a particular patient is at.
Well, I think that, again, the urodynamic study plays a role. And so that in combination with history-taking, a physical examination, in most cases we're able to recreate the patient's symptoms, but in some cases we're not, just because they're in a foreign environment or uncomfortable, and it's just not the exact same situation. So I would say that in combination with the patient's history and their physical exam, we should be able to determine exactly where they fall.
Perfect. That makes sense. So once that determination has been made by the physician reviewing the report, the examination, and the study information, at that point, what are some of the things that can be done to manage stress urinary incontinence for a patient?
Well, there are a number of things, and I just want to preface all of this with the fact that I am certainly not a doctor, and so the types of things I'm about to talk about cross over multiple lines in terms of what different doctors believe is the best course of action to take. And it's really incumbent upon the doctor to study these types of either therapies or surgeries or medications, that sort of thing, before moving forward. But it kind of breaks out into a couple of different areas. I'd say the first is more of a conservative management of stress incontinence. And I would say that kind of starts out with a physical therapy. So most doctors believe that you really should begin the process with a conservative approach and to kind of work your way up to more extreme approaches like surgery. So the first one might be, for example, pelvic floor training for at least 3 months. So that training would include at least 8 pelvic floor contractions or Kegels performed 3 times a day. And what we believe in is that you need to know whether you're moving the ball forward. And so a urodynamic study provides kind of a quantifiable approach to that because you've actually got data and data points to determine, did the pelvic floor training, for example, first of all, did they do it? So if they did it, did they decrease their stress incontinence? And so is it working, essentially?
So what you're saying is, with some of the management options you're discussing here, first with the physical therapy aspects, sometimes a urodynamic study at the beginning to determine where the patient is currently, and then potentially after a therapy period to determine has it improved using quantifiable data.
Absolutely. And so I think probably to clarify that even further, that you really want to use a urodynamic study as a baseline initially and to say, here's where we started. And it doesn't mean that we really need to do a urodynamic study at each step of the way, because I think that it's an invasive procedure. So we really want to go through the process of asking the patient whether, how they're feeling, if their symptoms are getting less. And then at some point down the road, you do want to run another urodynamic study just to see if the data points have moved and if there was value in the physical therapy or really in any of the treatment procedures that we're talking about.
Great. What else can be done from the conservative point of view for managing?
There's electrical stimulation should be considered in women who really can't actively contract their pelvic floor muscles. And then the third thing really is kind of a no-brainer, which is weight loss in particular cases. Obviously, significant additional weight will have an impact on the pressure, actually, of the abdominal cavity and thus the bladder itself.
Interesting. I think many people, including myself, might not be aware of that, so that's a good point that you can provide.
Great. So that's really kind of the conservative management side of stress incontinence. And as I said, I think that it makes sense to really know where you started, identify whether one of those processes is working, or if not, then I think only after that you move to, like I said, a more invasive surgical management. And that's, again, only if conservative treatment is ineffective. And some of those things, the surgical management really is, for example, a retropubic mid-urethral tape procedure using a bottom-up approach with macroporous propylene meshes. And so we're really talking about a sling, actually a synthetic sling using retropubic top-down or transorbital Foreman approach. And so those are things that, again, I have very little experience in terms of never actually done one of them, but these are some of the approaches that are out there via both through SUNA or through the AUA that we've identified. And really the last thing is kind of an intramural bulking agent, where they are bulking up the sides of the urethra and the sphincter, actually. And the one thing that the patient should be made aware that repeat injections may be required, and eventually the effectiveness diminishes with time. It's more of a temporary fix, really.
Got it. Okay. Anything else that our listeners might need to know about this side of urinary incontinence in the stress realm?
I would say that there are probably a lot more patients that have this than doctors know about. And
why do you think that is?
For a lot of people, there's a stigma, I think, involved with urinary incontinence and an embarrassment, even approaching it with their doctor. And so what the physician has to do is ask the question, have you experienced any problems with that, to really help solve the patient's problems. So it's just something that kind of sits silently in the background, and I think doctors have an opportunity to really help their patients by simply asking the question.
Well, that makes perfect sense. Well, that's all the time we have for today. On behalf of Darren Prescott and Mobile Urodynamics Group, this is Robert Caruso, and we look forward to seeing you again.